Okay, folks. Yes, thank you very much, Alice, for being our body on the bed. Thank you. I'm just going to quickly talk about beds. This is a profiling bed. This is one of the community profiling beds that we have got. But all profiling beds in the hospitals, they will work in the same way. Now, we have about 10 or 15 different types of profiling beds in the community. But I would remind people, follow your principles. It's like learning to drive a car. You follow the principles. They will all profile. The staff on the wards where you are will go through the profiling elements with you because they are all slightly different. But we do need to be very aware of a knee break and the head raising as well. This bed is now at its lowest, whereas when we leave the patient, this is where it would be left. When we come to do any form of moving and handling, it could be a drink, it could be giving tablets, it could be taking a temperature maybe, or it could be rolling for bathing. We then need to raise the bed. So the control's over there by Lisa. So it's an uppy-downy bed. So the bed will go up. Now, how high do we actually take the beds? So, if you could just take it up a little bit, please, Lisa. Sometimes they do take a little while, I'm afraid. And I know people say, oh, I haven't got enough time to do it. The sad thing is that if I don't put the bed high enough, thank you, Lisa, at that height, if I'm going to do something, say, doing, I don't know, checking a cannula or maybe doing a blood pressure, my temptation is to do, well, you're right, Alice, is that, which we all know is not following the principles at all. So I still need, if I am doing any work with the patient and the bed is low, I still need to follow my principles. I come at my diagonal angle, I get down like this, and I come and I'm using my up and down, my bobbing actions. Okay, thank you. This is not high enough for us to do any work. I know people working in the community, people in their own homes have to deal with this, and we do have to kneel on beds, but in the hospitals we raise the beds up. If the beds are not working, please get the estates guys to come and get them looked at as soon as possible. It is a vital piece of equipment. Thank you very much. Now, Lisa, are you happy to work with the bed that high?
It's probably...
It's okay for you. So, much the same height, but you have to think about the height of the person, and the height of the bed should go to the taller person. Can we take the bed, this bed, to its fullest height? Because this is a community bed, and I'm sorry for anybody over 5'7", these beds will not go high enough. Hospital beds are slightly different, and they will raise. You will be able to get your knee underneath. So for me, that will be right, because it's coming to my hip. But because I'm working with Lisa, we have to have a bit of a compromise, so we can go down a tad, yeah? Principles of our own moving always work. Okay, lovely, thank you very much. Now, once again, can I just check with Lisa? Lisa, is that all about the height of the bed?
Yes.
That I need, yes?
Yes.
Okay, thank you. Right, I'm now going to ask Alice again to show us natural. When you're in bed, how do you roll over in bed, Alice? Okay, we notice she follows the principles. Her knee comes up. She's only a one knee person, some people are two. Her head turns the way she's going. She's leading with her head. Her arm comes over her body, and she uses the power that she's got in her legs there. Thank you very much if you could do that. Now, that tells me that she can actually do that herself. Always ask your patients first of all, can they roll over? Bed rails, the bed rail assessments, your local staff will go through the policies of bed rails with you and about when to actually use a bed rail. But for some people, it would be quite all right for me to put the bed rail up, and I would say, Alice, can you pull yourself over with the bed rail? That is fine. In this case, we're not using it. Before I start to do any moving and handling with Alice, I notice that she's on an airwave mattress or a dynamic mattress. And an airwave mattress actually moves. It's like the actions of the waves. So before I do any moving and handling, what I'm going to do is I'm going to go to the junction box and I'm going to press the static button. Yes, I am now going to take the pattern of movement out. So remember, the first principle of moving and handling is a label base. Lovely, thank you. Most important. Okay. Is it all right if you roll towards Lisa this time? Okay. Oh, I do like that. I only gave the idea to her and she rolled. Fantastic. Saves me doing it. And back again. If she can't do that, then we're going to have to help her. So we'll think about what she did. Her legs. Yes, she might be able to bend her knee. If she could, I would say, Lisa, please bend your knee. If she can't, now, there might be reasons why she can't. She might have edematous legs. She might have problems with her knee. It is fine for a patient not to bend their knee. With some patients, you might actually put a pillow between their knees, or they might be flat. That is absolutely. What happens from person-centred care is you do what this person needs. I am going to bend Lisa's knees. Okay. And I'm going to come, what I like to do is I come from this side of the bed. I like to look up at my person. Eye contact is important with Alice. And I come in my staggered foot position and I'm just scooping underneath and just raising them up. If they need to be raised, I will do it that way. If it's in one leg, that's absolutely fine. You do what's appropriate.